Drooling, or sialorrhea, is the involuntary loss of saliva from the mouth. While it is a common feature of infancy, persistent drooling beyond the age of 4 years is considered abnormal and may indicate an underlying medical or developmental issue. There are two main types of drooling: anterior drooling, which occurs when saliva spills from the mouth and is visible externally, and posterior drooling, which involves saliva spilling into the pharynx, less noticeable but more dangerous, as it can lead to aspiration and respiratory complications. The causes of drooling are varied, and understanding them is crucial for effective management. Neurological disorders, such as cerebral palsy, amyotrophic lateral sclerosis, and Parkinson's disease, impair oral motor control and swallowing reflexes, leading to drooling. Developmental delays, particularly in children with oromotor dyspraxia, affect their ability to manage saliva, chew solid food, or speak clearly. Anatomical abnormalities like macroglossia, cleft palate, or micrognathia can mechanically disrupt saliva control. Other causes include hypotonia, poor lip closure, and impaired sensory awareness in the oral cavity. Persistent drooling can result in skin irritation and infection around the mouth and chin, social and psychological issues due to embarrassment or bullying, and aspiration pneumonia and recurrent respiratory infections, particularly with posterior drooling. The severity of drooling is often rated using tools such as the Drooling Severity and Frequency Scale, or the drooling quotient, which measures the frequency of drooling episodes during specific time periods, offering objective data for clinical evaluation. Patient history is key, focusing on developmental milestones, associated conditions, and the functional impact of drooling on daily life. Advanced diagnostics include video fluoroscopic swallowing studies and fiber optic endoscopic evaluation of swallowing, which are gold standard techniques to assess aspiration risks and the functional integrity of the swallowing mechanism. Microlaryngoscopy under anesthesia may be required to identify anatomical causes such as laryngeal clefts or tracheoesophageal fistulas. Management depends on the severity of drooling, the underlying cause, and the impact on the patient's quality of life. Behavioral and supportive therapies include speech therapy to improve oral motor control and postural training to enhance head and neck positioning to reduce drooling. Caregivers may be trained to use bibs, suction devices, or skin care products to manage symptoms. Pharmacological interventions include anticholinergic medications, such as glycopyrrolate or scopolamine, which reduce saliva production but may have side effects like dry mouth or blurred vision. Botulinum toxin injections into the salivary glands offer targeted relief, reducing glandular activity for up to 6 months. Surgical options include submandibular duct relocation, which reroutes saliva flow posteriorly, reducing anterior drooling, and gland excision procedures, such as parotidectomy or submandibular gland removal, reserved for severe cases. Laryngotracheal procedures may be necessary to address aspiration in posterior drooling. A multidisciplinary approach involving collaboration between ENT specialists, speech therapists, neurologists, and pediatricians ensures holistic care tailored to the patient's specific needs. Drooling is not merely a cosmetic issue, but can significantly impact health, quality of life, and psychosocial well-being. Early diagnosis and a tailored, multidisciplinary treatment plan are essential to improving outcomes for patients with sialorrhea.